Hi everybody, this is Lisa and welcome to your video lecture. The topic for this module is ageism. So here are our objectives for this class. We are going to discuss the concept of ageism and ageist stereotypes. We are going to explain how ageism affects the health and well-being of elder adults and describe how ageism in healthcare professionals impacts care delivery. So what is ageism? Now, ism in any form is dangerous and detrimental, not just to whom it is directed, but to society as a whole. Your book describes ageism as the systematic labeling and discrimination against people who are old, which is good as far as it goes. But I really like this definition by the Ontario Human Rights Commission, which breaks it into two separate but complementary concepts. A socially constructed way of thinking about older persons based on negative attitudes and stereotypes about aging, and a tendency to structure society based on the assumption that everyone is young and that young is better than old, thereby failing to respond appropriately to the real needs of older persons. Now, this systemic way of thinking and acting, again, that everything younger is preferable to everything older, results in limited opportunities and resources allocated to the support of older people in the society. At its very worst, it can lead to real physical harm and abuse for some older people. I like the definition of a stereotype as a widely held but fixed and oversimplified image or idea of a particular group of people sharing similar characteristics. We perpetuate these stereotypes when we say, for example, when we forget something and call it a senior moment, as if all older adults had significant and impairing memory loss, or when we remark that you can't teach an old dog new tricks. These stereotypes lead us to make some broad assumptions and generalizations about older people which simply are not based in fact. Your book lists a number of popular myths about older people, things that run the gamut from all older people are senile to older people are not sexual beings. Now, one of my favorite stories about a kind of aha moment when this happened way back in about 2003, when I was a brand new nursing instructor leading a group of nursing students in a clinical experience at one of the nursing homes. On our assessment form was a section on sexual health, and one of my much younger students was mortified that she was going to have to ask her 80-year-old patient about sex. When she finally swallowed her discomfort and did ask the man, she got an earful about how difficult it had been for this man to find some private space in the facility to be intimate with his partner, who was there pretty much every day but didn't live at the facility. My student marveled at this information, and not even just so much that the patient even had sexual relationships at his age, but that he was so willing to be forthright about it when he was asked. She admitted she never thought of elderly people as sexual beings before, and that encounter really made an impression on her. Ageist language is probably the most obvious expression of ageism that we can see. And I'm always amazed at how people who would never dream of uttering a sexist word, for example, at least not on purpose, think nothing of throwing around terms like old battle axe or fossil, or referring to especially elderly females as Q-tips or blue hairs. Nowhere is ageism more apparent than in our media portrayals. Older people, when they're portrayed at all, are usually portrayed in a stereotypical way. Your book lists a few shows that they point to as playing up age as something to laugh at or pity. I myself can think of some ageist portrayals I thought at the time were funny. Fred Sanford and Sanford and Son, for example, or Sophia Petrillo in The Golden Girls, that I now cringe at. And if you looked at the state of advertising, you'd think the only things older people ever purchased were wheelchairs or other mobility aids and erectile dysfunction meds. The most desirable demographic for most advertisers is 18 to 49, long before a person even becomes young old. Healthcare professionals are socialized in the same way as everybody else. So it's natural that we hold a lot of the same ageist beliefs and assumptions as society at large. As a result, geriatrics as a medical specialty is underappreciated relative to the need, for sure. It doesn't hold a lot of prestige the way other specialties like cardiac surgery does. There is the tendency to be both overprotective of older people, those poor old souls, it's terrible to be that aged and infirmed, and the way they speak to and infantilize sometimes older clients reflects that. The infantilizing habit of calling an older person honey, for example, persists, especially in congregate settings like long-term care facilities where older people really are dependent on others to get their basic needs met. But at least the care workers in those facilities have chosen to work with the elderly. In a lot of other areas of healthcare, there's downright hostility expressed to older adults. Your book lists a few, and Gomer is the one I have probably heard most often, a term that usually refers to a frail or dependent older adult in an acute setting, such as an emergency room or hospital unit, uttered by a healthcare provider who would rather work with a younger person with what they perceive to be more worthy or interesting problems. It really is demeaning, and you can really see how that would affect the care that's provided by whomever is expressing that view. Now, we know a lot from studies. Your book runs down several. I've posted summaries of 2 more recent ones in your module folder, that having ageist beliefs and being exposed repeatedly to ageist stereotypes is detrimental to the health and well-being not only of the older adults themselves, but also to their younger counterparts. In a way, for the older adult, it can become a self-fulfilling prophecy. If you believe, for example, that all elderly people lose their memories and ability to care for themselves, then you're going to expect to see that same decline in yourself and act accordingly, not engage in behaviors that might lead you to a better outcome. In fact, just the opposite appears to be true, that the more positive attitudes about aging result in better self-care, better functional status, and a better ability to recover from a health setback. Again, I put a couple of articles that address this issue from an empirical perspective. The first one is the National Poll on Healthy Aging, published just earlier this year, I think it was June of 2002, which looked at older adults' self-report, what the older adults themselves said about their health, and compared it to how often they were exposed to ageist attitudes. And they found that the more often people reported seeing and hearing this type of talk and attitude, the more likely they were to report poor overall physical and mental health. Now, obviously, correlation does not equal causation, but it really is an idea and some findings that will likely be followed up on with more studies in the future. The other one that I posted was by Drs. Oshida and Lamb. I believe this one was May, maybe, about the effects of ageism on the healthcare delivery system. We've talked about a couple of these. The first one is the perception of geriatrics as a less rewarding healthcare specialty. That people who are interested in geriatrics as a professional career path just don't receive the respect and support of some of our other healthcare avenues. And that really does lead to a decrease in the amount of healthcare professionals who are interested in going into geriatrics. And as we know, geriatrics, the over 65 population, is the fastest growing part of our fastest growing segment of our U.S. population, and the fastest growing segment of that is the over 85 population. So a lack of providers really does lead to less efficient care. There is, of course, the undertreatment of what's considered old age issues, such as memory loss, sexual dysfunction, educating people about safer sex, for example. And so if you think that memory loss is just a part of aging, and that nobody over 65 is ever interested in having sex, you are not going to bring that up or talk about it as a treatment, something that can be treated. The article also talks about overtreatment based solely on age recommendations. They mention prostate cancer as an example of that the guidelines basically said, yes, you screen everybody for it. But we do know that prostate cancer is something that can very often outlast an old man. And so there's a disagreement around what the actual treatment is going to be when you find it. Ageist language, we did talk about it. Poor communication practices, and this kind of loops back to our health literacy module that we did a few weeks ago. I believe the article refers to it as elder speak, but what it is basically talking to people as if they were much younger, like children, or talking to the younger adult child or caregiver, and just assuming that the older person is not in charge and doesn't make decisions about their own health care. I've seen doctors and nurses and other healthcare providers, turn to a family member and talk directly to them, even though the older adult is sitting right in front of them. Ageism in the older adult themselves. Again, we are all socialized under these same conditions. And so older adults have ageist beliefs as well. And those beliefs can lead to the acceptance of many potentially treatable conditions as part of old age. Institutionalized ageism occurs when healthcare practices don't take the older adult into consideration. And the article talks about many provider practices that will not accept Medicare and Medicaid payments. And I would say ostensibly this is because the reimbursement rates for these two programs are substandard. They are lower than you might get from a United Healthcare or Anthem or something like that. So that does have some merit to it, but the other merit is that by limiting your practice to only clients who have private insurance means you don't have to deal with the older adult population that closely, and especially not the older adult population that is also economically disadvantaged. And finally, a lot of our what we call evidence-based treatment standards come from the study of younger adults who don't also have the burden of several chronic illnesses and medications. We very often look at these things in, it's an overused term, but in silos, whereas hypertension can be treated this way because this is what our evidence tells us to do. Heart failure can be treated this way because this is what the evidence tells us. Well, the evidence is based on very small population samples, demographics. Most of them are from younger adults who don't also have the burden of several chronic illnesses and the medications on top of that. So while if somebody has standalone hypertension, which I'll use because it's easy, that doesn't take into account the other illnesses the patient might have. A lot of the treatments that we use for hypertension can mask symptoms, for example, of other things like diabetes or depression. Again, and here are some suggestions for combating ageism in healthcare workers that came from the previous article. They talk about education and information campaigns, trainings among healthcare providers on how to recognize ageism, how to overcome those beliefs of their own, increase the opportunities essentially for older people to be more visible and in different roles, policies enforced to avoid age discrimination. And I will say, there's a lot of empirical evidence, it's not about healthcare necessarily, that shows that even after the age of 35, age bias starts to build in our employer base. So it is much harder even for even for an older young person to be competitive, much less somebody in their late 50s. We want to figure out the best way to spend public funds because healthcare in this country is enormously expensive, and the outcomes don't always reflect the amount of resources we think we put into it. We want to increase the healthcare workforce trained in geriatrics, address the growing demand for long-term care, and I would say long-term, not just long-term care, but assisted living, in-home care types of situations. Again, our population is only getting older, and we currently don't have the services in place to match what we need now, much less what we're going to need in 20 or 30 years. We want to find better ways to make sure that our elderly population is not living in poverty. We want to help people who are caring for spouses, parents, without payment. And we also want to make sure that we are engaging in research on the best practices for the issues of the elderly. Okay, that's it for this module. Thank you for your attention. Just like the science says, aging is not a disease, and it is clear we as healthcare professionals really need a lot of education and support to change our thinking and behavior around this. Have a great day and enjoy the module.